Hello, and thank you for attending this workshop. I am Dr. Nina Vinkoff. I am a radiologist specializing in breast imaging, and at Northwell Health, I'm a vice chair in the Department of Radiology and the chief for the Division of Breast Imaging. Today, I am honored to be moderating a conversation between two of my colleagues who are experts in breast cancer care. I have Dr. Saada Dasari and Dr. Cindy Sen. I will allow them to introduce themselves in a moment, but I wanted to tell you a little bit about our workshop, which is entitled, I Found a Lump, Now What? We are going to be talking about some of the changes that women may experience in their breasts, what's normal and what's not, and when you should talk to your doctor and what kinds of testing your doctor might do. Before we begin, I'm going to allow my panelists to introduce themselves, and I'll start with Dr. Sen.
Hi, everyone. My name is Dr. Cindy Sen, and I am a surgeon at Northwell. I am from New York originally, and I did my undergraduate studies at Harvard. I went to medical school at NYU. I went on for my surgical training at Northwell, followed by my specialization in breast cancer care at NYU, and now I'm back here at Northwell. I operate at Forest Hills Hospital, Long Island Jewish, and Glen Cove Hospital.
Excellent. And Dr. Dasari?
Hi, everyone. My name is Saada Dasari, and I'm the Director of Women's Imaging at Phelps Hospital in Sleepy Hollow, New York, a part of Northwell Health. I'm truly passionate about breast imaging. And to give you a little bit of information about my background, after attending college at Johns Hopkins, I went to medical school at Albert Einstein College of Medicine in New York, and then did a residency in diagnostic radiology at Westchester Medical Center. After 1 year in Pittsburgh doing a fellowship in women's imaging, I returned to New York and began working at Northwell, and I've been here ever since.
Excellent. I'm so happy to have both of you here today to discuss these important topics. I'm going to be starting with Dr. Sen. Dr. Sen, many women have questions about what's normal and what's not when it comes to their breasts. They aren't sure what they're feeling and whether it's important. What kinds of changes should women be looking for in their breasts, and when should they talk to their doctor?
Right. This is definitely something that I ask all my patients, regardless of why they come to see me. The changes that I ask about are any lumps, any nipple discharge, any changes to the nipple or the skin. Lumps are kind of obvious, though many women have lumpy breasts and they don't necessarily know what a normal lump is versus a lump that might be more concerning for cancer. The lumps that I worry about are those that are hard, feel kind of out of place, or those that grow in size. For nipple discharge, this can be a normal finding, especially in younger women who may have recently had a baby or completed breastfeeding. Discharge is milky, especially if it's coming out from both sides and only with squeezing. That's not usually a cause for concern. But when discharge that comes out by itself, which we call spontaneous, if it's bloody, if it's coming up from just one side, those are red flags that require further workup. Other changes to the nipple or skin, that's important to watch out for. Say new nipple retraction or inversion are things to bring up. Some women may have naturally inverted nipples, and that's not a cause for concern. But if they previously pointed outward and over the past weeks or months, one of them has started to pull back, to retract, invert, that needs to be investigated. Skin changes to note involve like a scaly rash that might develop on the nipple. Also any kind of swelling, redness, dimpling of the skin of the breast. That can be something as simple as a breast infection, but can signify something more serious like an underlying cancer. In these cases, I would advise a patient to get breast imaging done, and that might possibly lead to a biopsy.
As we know, many women actually experience pain in their breasts. It's very common. Dr. Dasari, when is breast pain normal, and when is pain something that should be evaluated by a doctor?
The good news is that although breast pain is uncomfortable and can be very bothersome, it's usually not associated with a breast cancer. So quote unquote normal breast pain usually involves both breasts. It's cyclical, meaning it comes and goes in a pattern that's predictable and related to your menstrual cycle. So this type of pain tends to get worse in the days leading up to your period and then lessens after you have your period. And pain that we would consider to be more concerning would be the type that's only in one breast or in one specific location in one breast. And it would be persistent, meaning it's not that cyclical type and it doesn't change with your menstrual cycle. It's there every day. Accordingly, pain in a woman who is postmenopausal would also be a little bit more concerning as well.
Okay, thank you. There's been some difference of opinion in recent years about whether women should do regular self-breast exams, or whether instead of doing a self-breast exam, women should just be aware of what's normal for them and for their own body and be alert to changes. Dr. Sen, do you advise that women do regular self-breast exams?
Yes, absolutely. I think that women are a little intimidated by the term breast self-exam. They think that they need a medical degree to be able to do one properly. But I stress to them that it's all about being body aware. The important thing is really to get to know your landscape, to know the texture of your own breasts. And that way you can really say that if you notice a new lump, there's a change to the nipple, you can be confident in saying, this is not normal for me, this is new, and this is concerning. And that can lead to an earlier mammogram than your normally scheduled mammogram, and that can lead to an earlier diagnosis and lead to better outcomes.
Okay, excellent advice. Thank you so much. Again, Dr. Sen, can you walk us through what happens if a woman comes to your office with a new breast symptom? It could be something that she found herself, or something that her doctor or gynecologist found on a clinical breast exam. How do you determine if further testing is needed, and what kind of testing might you order?
Right. So usually before coming to see me, having heard about, say, a new lump or a new finding, I would prefer that a patient get certain studies done first. For women over 30, a diagnostic mammogram and an ultrasound are good ways to investigate if something is underlying that symptom. For women under 30, usually just an ultrasound is ordered. Mammograms may not be as helpful for younger women. But in either case, if something is seen, then a biopsy may be the next recommendation. These are performed by you guys, the breast radiologists. When the results are available, then the patient is welcome to come see me in the office, and then we can talk about what the next steps might be, whether further surveillance or maybe surgery. Sometimes, someone may have a symptom, but nothing is seen on mammogram or ultrasound. And at that point, I have the patient come in and we can talk, and then we can decide if maybe further imaging like an MRI might be appropriate.
So you prefer that a patient have their imaging done first and then come and see you afterwards, so that you're able to discuss their imaging exam with them when they come and have their consultation in the office?
Correct, exactly. That way, if they need a biopsy, then we can talk about what that shows and we can make a plan with that information.
Excellent. So Dr. Dasari, we know that there are two different kinds of mammograms. There's the ones that we call screening, and there's the ones that we call diagnostic. And this can really be a topic that's very confusing for women. What is the difference between a screening mammogram and a diagnostic mammogram? And which mammogram is it that a woman who has a new lump or a new symptom or a change in her breast should be having?
So you're absolutely right. This can be very confusing for women and referring physicians as well. So I'll try to simplify it a little bit. So a screening mammogram is just the terminology that we use to describe a mammogram in a woman who has no breast symptoms or no breast concerns at all. So no lump, no nipple discharge, none of those things. So she would be simply having her annual exam that she gets once a year. The woman that has the screening mammogram done usually just has the test performed and then goes home right after, and then she gets her results either by a telephone call or by a letter in the mail. Now, a diagnostic mammogram is the terminology we use for a mammogram that's done in a woman that has some kind of breast concern. So it could be any of these breast changes that we've talked about today: a lump, pain, focal pain, or nipple discharge. And after she has this diagnostic mammogram done, a radiologist will look at her images immediately and then decide whether she needs any additional mammographic views or if she needs a breast ultrasound. And then these studies would be performed right away, and the ultrasound technologist would scan the patient if necessary. And often the radiologists may come in as well and take a look themselves with the ultrasound. And then before the patient leaves the department, the radiologist will give the patient the results of all the tests that they've had done and give their recommendation about what kind of follow-up would be needed. And if they do see something concerning, then they would recommend a biopsy at that time. If they see something benign, like a cyst, then the patient would just be advised to come back in a year for their annual screening mammogram. Once in a while, we'll recommend a shorter term follow-up as for example, in 6 months usually. And that's just to keep a closer eye on a finding that we think is most likely and probably benign.
Thank you so much. I think the reason why it's confusing is because we have these two different names. And I know I personally have had women say to me, are we using a different machine? Is there a different technique that we use? And, the basic answer for that, as you and I both know, is it's the same mammogram machine that we use, but it's the way that we take the pictures. So for a screening mammogram, we're just going to take the 4 standard pictures. Whereas for a diagnostic mammogram, depending on what you tell us the problem might be, we might choose to take different kinds of pictures. And that's the difference. And the other difference, as you stated, is that when you're having a screening mammogram, you're probably going to be getting the results after the fact. Whereas with a diagnostic mammogram, absolutely 100% of the time, you'll be getting the results before you leave the office and an answer to the question that brought you there. So Dr. Dasari, this leads me to the next topic, which is what's the difference between a mammogram and an ultrasound? And should a woman who have new symptoms have a mammogram, or should they have an ultrasound, or should they have both?
So a mammogram is a set of pictures that's taken of the breast, and it uses very low dose, very low energy x-rays. So we place the patient's breasts in compression as we take the pictures. And this helps us to reduce motion and get clearer images so we can find subtle findings. The radiologist can then look at these images, and they use a special monitor searching for any signs of cancer. And the mammogram can actually be done in 2D or 3D. And at Northwell, we use 3D as our standard of care. So an ultrasound is an exam that most women are probably already familiar with if they've had children, as you tend to have a lot of these when you're pregnant. And a probe is used to scan over the breasts, and gentle pressure is applied as they do it. And the woman is generally lying on their back or on their side when this is happening. And the ultrasound machine works through the use of sound waves. So there's absolutely no radiation involved, like with a mammogram. And we take images of the breast. Usually it's performed by an ultrasound technologist and then evaluated by the radiologist. And like I mentioned, sometimes the radiologist may come in and scan his or herself to get a better idea of what's going on in real time. So women with new symptoms may need to have one or both of these tests, a mammogram and or an ultrasound. Generally, like we mentioned, if you're older than 30 years, we would start with a mammogram first and then do an ultrasound as well if we think it's necessary. If you're under 30 years old and have new symptoms, we usually start with an ultrasound just because there is that lack of radiation exposure. And with younger women, we want to be a little bit more cautious about radiation exposure because their breasts and body in general is a bit more sensitive to the effects of radiation. And then if we truly think a mammogram is needed in these younger patients, we can always get one after the ultrasound's done.
Thank you very much. I think it's difficult for a lot of women to understand what the difference might be, and a lot of it, I think, really just comes down to X-ray is what we use for mammography, sound waves are what we use for ultrasound, and then magnetic waves are what we use for breast MRI, which we're not going to talk about a lot here. And I have women ask me all the time, why do I need to do both? Or, why can't we just have one kind of test? And I think really the answer is because each one of those kinds of energies give us a different kind of way of looking at the breast. And we haven't found the one test that does it all perfectly. They each see things a little bit differently. So Dr. Dasari, I have a question for you. You talked a little bit about radiation exposure, and I know there's a lot of confusion about this topic. What if a woman notices a change in her breast during pregnancy? Can she still have a mammogram?
The answer is yes. Yes, she can have a mammogram, even if she's pregnant. And if she notices a change in her breast, she really should have the mammogram. And the reason is, if she does have a breast cancer, it could be pretty fast growing, especially given the hormonal changes that happen during pregnancy, the higher estrogen and progesterone levels specifically. So if a woman is pregnant and she has some kind of new breast symptom, we usually start with an ultrasound just to see if that will answer the question about what's going on. If that doesn't, however, then a mammogram can be very helpful to answer that question. And the amount of radiation involved is very, very low. And because the energy of the x-rays themselves are very low, they don't travel very far away from the breast to other parts of her body, including her belly. But in any case, To be extra careful, we can place a lead shield over the pregnant woman's belly, and this provides some additional protection for the fetus as well.
Thank you. I think it's really important for women who are pregnant or breastfeeding, we'll talk about breastfeeding a little bit in a minute, to remember that not only can you get breast cancer when you're pregnant or breastfeeding, but certain kinds of cancers are going to grow fast during times that you have that kind of hormonal stimulation, and to not put off getting these things evaluated because of fear. Because as you rightfully said, the dose from a mammogram is very, very low, not dangerous to the fetus, and really important that you get new symptoms evaluated when you're pregnant, because they could be something important. Dr. Sen, let's talk a little bit about breastfeeding. Lots of women experience changes in their breast during breastfeeding. It can be very, very confusing to know what's normal and what's not, especially if it's your first time breastfeeding. So what kinds of things should women be alert to while they're breastfeeding?
Right. Breastfeeding is it's a really natural way to bond with your baby, but it's not easy. And I know that from experience. Particularly in the very early stages, right after birth, the breasts become engorged, very uncomfortable. It takes a while for the supply to regulate. And if the breast doesn't empty fully, the milk ducts can get clogged, which leads to inflammation. And that inflammation of the breast is called mastitis. The breast can feel swollen, it's red. The milk ducts again, they're not draining, and it can be very painful. So when untreated, it can progress to the woman having fevers, feeling sick like having the flu, and then ultimately form an abscess that will require drainage. The best thing to do is to treat mastitis early with antibiotics and to fix the underlying problem, which is usually that clogged milk duct.
Excellent, thank you. So again, it comes down to getting attention when you notice a change, and not to be embarrassed, I think, especially if it's your first time breastfeeding and not knowing whether what you're feeling is normal or not. Better to show it to your doctor and find out whether it is or not than to take a problem that might be small and have it turn out to be something bigger. And of course, you mentioned mastitis, but as we know, breast cancer can also occur during breastfeeding. So all the more reason why, if you're not sure what's going on, if you're not sure what's normal for you, to show it to your doctor. So Dr. Dasari, what are some of the things that you might find on a mammogram or an ultrasound if a woman's having a lump? And what kinds of things might you find that are normal? And how do you know when to recommend a follow-up exam? And how do you know when to recommend a biopsy?
So, if a woman feels a lump, it can be due to a number of reasons. And the good news is that it's usually due to something benign like a cyst, and cysts are very, very common in women. It could also be due to a lymph node or a benign solid mass, like something called a fibroadenoma, which is very, very common as well. So if we see a concerning or an indeterminate finding on a mammogram or on a breast ultrasound or both studies, we would recommend a biopsy. And concerning findings have a particular appearance, and that's how we decide which ones to recommend a biopsy for. So they may be really dense in appearance, very irregular in shape, or even cause some pulling in of the surrounding tissue around it. And occasionally the radiologist will make a finding on the mammogram or breast ultrasound and describe it as quote unquote probably benign. And that just means that there is a very, very small chance of this type of finding being an actual cancer, less than 2% chance, in fact. And this is the situation where we would recommend that the patient come back for a shorter term follow-up, just to make sure it doesn't change in any sort of concerning way. And the follow-up is usually done in 6 months, but can vary a little bit. So for example, a finding on ultrasound that we might recommend a 6-month follow-up for may be a mass that's very oval and round and not irregular in shape at all, and one that we would feel comfortable saying this is most likely going to be a benign finding.
So just to paraphrase a little bit what you just said, it seems like there's 3 different categories of things that women should be aware could happen when they go and get their finding evaluated with imaging. One is that we see something that we know is normal, and we can tell you right there and then that's normal. That's a cyst, it's normal, nothing else needs to be done. There are some things that we say, we're not sure, that might be a cancer, we're gonna need to do a biopsy in order to know. And then there's that third category that you just mentioned, that we feel very, very confident that this is not going to be a cancer, but we want to keep an eye on the area just to make sure. There's a very small chance that it could turn out to be something important. And so we're going to have you come back again in 6 months just to make sure that there hasn't been any change. And then if there has, maybe at that point we would decide to do a biopsy. So, Dr. Dasari, both radiologists and breast surgeons, as we know, can do needle biopsies. Here in Northwell, most of the needle biopsies are done by radiologists. Can you just briefly walk us through what it's like to have a breast biopsy? If something is found on a mammogram or on an ultrasound, how is the biopsy performed?
Sure. So there are 3 types of breast biopsies that we perform as radiologists. And the difference really is the type of imaging that we use to guide the biopsy itself. So if we see a finding on breast ultrasound and we decide to biopsy it, we perform the biopsy under ultrasound guidance. And this is really the easiest and quickest type of biopsy that we do. The patients prefer it compared to the other types because their breast does not have to be in compression. The patient actually is lying flat on their back during the procedure, and we just clean the skin. We give a little bit of local numbing medication, usually with lidocaine, through a little needle, and then we insert a small needle into the breast and take a few samples of the area of interest. We then place a tiny little biopsy marker in the location where we do the biopsy. And that's just to mark the area in case it can't be seen well after the biopsy is done. And we are visualizing the area that we're working in with ultrasound guidance throughout the entirety of the procedure. And that helps us to make sure that we're taking really good samples of the target. Now, if a finding can't be seen with ultrasound, but only on a mammogram image or only with MRI imaging, then we perform the biopsy using that type of guidance. So either mammographic or MRI guidance. And a biopsy that's done with mammographic guidance is called a stereotactic biopsy. And in that type of biopsy, the breast does have to be placed in compression. We take a few pictures to find the area that we're looking for and make sure that we sample it well during the procedure. And just like with any type of biopsy, we then just clean the skin, we give local numbing medication, and we put a little needle in and take several samples. And then at the end, a biopsy marker is placed. So an MR guided biopsy is done when we only see the finding on MRI and not on the mammogram and not on the ultrasound either. And in this type of biopsy, the patient would have to lie face down on the MRI table with their breast hanging down through a special biopsy coil to support the breast. And we do have to use some breast compression for this type of biopsy. So in this case, the woman would be placed into the MRI scanner to obtain the images and find the area and make sure we sample it well. And they are placed in the scanner intermittently as we do the biopsy, not for the entirety of it. And then again, we just clean the skin, we give local numbing medication, put a needle in, and take a few samples of the target. And then afterwards, as always, a biopsy marker is placed in that area.
Thank you. I think, one of the things that I think is scary if you've never had a biopsy is that sounded like a lot of description. But I think Dr. Dasari and I could tell you that each one of those kinds of biopsies actually only takes us a few minutes to do. And a lot of the time that you're in the office is just the preparation for the biopsy and then sort of cleaning up and giving you the instructions afterwards. But the time that you're actually in compression for your mammogram or lying on your back having the biopsy and ultrasound or lying on your belly having the biopsy and MRI, those periods of time are short. And we give you lots of local anesthetic, so you're all numb during it. And it's really not an uncomfortable or unpleasant experience for the majority of women. And most people actually leave our office. A lot of people will go back to work as long as you're not going to be doing strenuous activity or heavy lifting. We don't need to give you anything that would impact you from driving or any other kind of activity. It's usually just a little ice pack and maybe some Tylenol if you're having more discomfort than what we can take care of with the ice pack. So not all biopsies are going to find cancer. And I think that that's a really important thing for women to realize. And in fact, it's actually the minority. Only about a quarter of all the breast biopsies that we do find breast cancer, which means that 3/4 or more of all the things that you might be recommended to have a biopsy for are not going to turn out to be cancer. And I think that's really important to remind yourself if you're somebody that gets recommended to have a biopsy. Still, most likely, we're going to find something that's not cancer. So Dr. Sen, what are some of the things that we find on a breast biopsy that are not cancer? And which things need to be treated with surgery? Which things need to be removed?
Right. Definitely. I do, again, stress to my patients that the majority of biopsy recommendations lead to benign findings, but there's certain benign findings that still are considered high-risk lesions or high-risk findings that require surgery to make sure that there's not an early-stage cancer that might be nearby. These findings include intraductal papillomas, radial scars, atypical ductal or lobular hyperplasia, and something called LCIS, that's lobular carcinoma in situ. That term contains the word carcinoma, and that freaks out a lot of patients. It's scary to hear, and some people might recognize its ductal counterpart, DCIS, ductal carcinoma in situ, that is actually considered early stage cancer. But LCIS, the lobular carcinoma in situ, is not. It's considered just a marker for cancer. So if we see that on a biopsy, again, it's benign, but that along with the other diagnoses, the intraductal papillomas, the radial scars, et cetera, these patients come to see me and we talk about doing an excisional biopsy of that area in question. And again, even after excising these areas, most of the time there's no upgrade to cancer, and that's great. But even if the surgery doesn't find any cancer now, they are still considered to be at high risk for developing cancer in the future. And so for these patients, I tell them a few things. One thing is they should undergo further screening. So in addition to the yearly mammogram, I think some of them might qualify for a yearly screening MRI. They can also meet with a medical oncologist where they can be offered medications that can lower their risk for breast cancer in the future. And for women with these high-risk findings and maybe some other high-risk factors as well, like significant family history, then we can talk about prophylactic mastectomies. But again, I reserve that for the very highest risk patients.
So there's really, again, there are 3 different categories of things that can happen after you have your biopsy. You could get a call to say it's completely normal, nothing there to worry about or think about, something like a fibroadenoma that has no chance of becoming cancer. It could be the situation, the small percentage of cases where it does turn out to be a cancer, or it could be one of these in-between or high-risk things that you just talked about, where you might need to have surgery so that it doesn't become a bigger problem down the road. You might even consider taking certain kinds of medications that are going to prevent you from or help reduce your risk rather for developing cancer down the road. But there's a lot of terms with a lot of big words that people may be saying to you after you have your biopsy that are not cancer, but that still might require a little bit more work before we're done. So those are things to keep in mind, that the call is not going to be yes or no. Sometimes it's a longer conversation after you have the biopsy than just everything is fine or you have cancer. Sometimes it's one of these in-between conversations. So that's something to be prepared for when you're having a biopsy, that kind of conversation could happen. So Dr. Sen, if a woman has a breast biopsy and it does turn out to be cancer, what happens next? What kind of testing is done next? And how do you decide what's going to be the best course of treatment?
Right. So unfortunately, while a lot of biopsies are benign, that minority does find cancer, and that is every woman's worst nightmare. The good thing is that breast cancer, kind of good, is that it is common. So this journey that follows is one that is very well established. A lot of women have gone through it, and so the guidelines, there's a lot of support out there, and so there's very common things that happen after. So first, after the diagnosis on the biopsy, additional tests. First, they do testing for 3 receptors. There's the estrogen receptor, progesterone receptor, and something called the HER2 receptor, which is just a special protein. Once we know where the cancer stands on each of these, then that further dictates what kind of treatments are available. At this point, I meet with the patient. We go through the diagnosis. We go through what these, again, the estrogen, progesterone, and HER2 receptors are. And then we talk about surgery. Mainly, the 2 options are either removing the whole breast, which we call a mastectomy, or taking just the part of the breast with the cancer in it, which we call a lumpectomy. This is breast conservation. Other parts of breast cancer care involve include chemotherapy, radiation, and or hormonal therapy. And that depends on exactly what kind of cancer you have. Most cases are straightforward, but for the ones that are less so, at least at Northwell, we have conferences twice a week where the different disciplines come together: the surgeons, the medical oncologists, the radiation oncologists, the breast imagers, and the pathologists. And we discuss the cases that are not that straightforward. As a team, we come up with a treatment plan.
Thank you. I think it's really important for women to know that there isn't just breast cancer. There's not one thing that's breast cancer. Breast cancer is really a huge umbrella of a lot of different things. And so what's going to happen to you next if someone tells you that you have breast cancer really depends on so many specific factors that are specific to you and to what's going on in your breast. And so your breast cancer is not the same as your friend's breast cancer or your mother's breast cancer. And I think it's also really important that women not spend too much time Googling about breast cancer, because what you read might not actually apply to your situation. You know, this is why we have groups of experts that decide how to treat each woman, is because each situation is different. And so while it's nice to get support from your friends, and you certainly, if you turn out to have breast cancer, you certainly will hear of lots of people that you can talk to, just keep in mind that their situation might not be the same as yours. I really want to thank both of you for this discussion today. It's been a great discussion, and you've provided a lot of information and hopefully taken some of the mystery out of what's important and what's not, what kinds of testing we do, what a biopsy experience is like, what kinds of results you might get from your biopsy, and what kinds of things might happen next. And I really believe that knowledge is power, and that for women who are watching this, knowing what to expect will hopefully be really comforting should you find yourself in any of these situations. I wanted to give each of my panelists an opportunity to give me some closing thoughts. So Dr. Dasari, if there's one thing that you hope that our viewers take away from this session today, what would it be?
So first, I want to thank everyone involved today for helping to educate women about their bodies and specifically about breast health. Like you said, there's a lot of misinformation out there on the internet and confusing information. So forums like this are a really great way to weed through all of that and get some real answers. And what I would like viewers to take away from this is, if you notice something different about your breasts, just say something. Say something to your primary care doctor, your OBGYN, and definitely say something to your radiologist when you come in for your imaging appointment. This is very, very important. And I would like women to also keep in mind that as breast radiologists, we understand that the whole process of breast imaging, whether it's screening or diagnostic imaging, and waiting for the results of these tests and biopsies can be very, very stressful for you. And we've really tried to do our best to minimize the stress as much as we can.
That's absolutely true. And I think I really wanted to emphasize one point that you made in there, which is about the importance of communication. When you come in to have your exam, please tell us what's going on. Sometimes we have patients who don't share the whole story of what they've been experiencing, and we can only do the right test when we really understand what's going on. So please don't be afraid to tell us, or don't think that we will figure it out based on the images that we take. Sometimes we take special pictures based on what you told us. And if you don't tell us, we're not going to take those pictures. So thank you so much for making that really important point. And Dr. Sen, any closing thoughts?
Yeah, I echo everything that Dr. Dasari mentioned. I think those are all great points. I hope that today's talk will encourage women not only to get their mammograms done, but also to feel empowered to examine themselves and be more body aware, to really get to know your baseline. And then you can recognize these changes and findings that are worrisome. And we cannot prevent a woman from getting breast cancer, but we can certainly find it earlier. And then at that point, people have better options and the outcomes are overall better when we treat earlier stage cancers.
I love what you said about empowering. I think there's a lot of fear when it comes to breast cancer. And I think it's really great if we can reframe everything that we talked about today as a way for you to take some control over your own health. And I think by doing that, you increase the chances that you're going to do well and go on to live a long, healthy life afterwards. So thank you so much to both of my panelists. This was a great conversation. I loved having the opportunity to talk with both of you. And thank you so much to the viewers for your attention. Thank you, Northwell Health. and the Katz Institute for Women's Health for inviting us to present this workshop. And thank you to the 92nd Street Y for partnering with the Katz Institute in this Breast Health Summit. Together, we are raising health for women. Thank you.